It's 6:45 a.m. on an ordinary Tuesday in March 2019, and 44-year-old marketing manager Diane is getting ready for work. She glances in the bathroom mirror and notices something odd. With every heartbeat, her fingernails seem to flush pink, then pale, then pink again, in perfect rhythm with her pulse. She holds her hand still under the light. It's not her imagination. She laughs it off, snaps a photo for a group chat, and heads out the door. 6 weeks later, she's in an emergency room with crushing shortness of breath, unable to lie flat, gasping for air propped up on 3 pillows. A cardiologist is telling her that the valve in her heart has been leaking blood backward for years, and that pulsing in her fingernails wasn't a curiosity. Often, it leaves quiet clues, written directly onto your skin, your nails, your eyes, and even your tongue, sometimes for years before a heart attack, stroke, or heart failure ever occurs. Today, we're going to walk through 13 visible physical signs of heart disease that you can actually look for and test on your own body right now. Drawing on more than a century and a half of medical observation, from doctors in the 1800s squinting at pulsing neck arteries by candlelight to the smartwatch on your wrist today that's quietly screening your rhythm for a stroke-causing arrhythmia. So let's dive right in, starting with the first sign is called Frank's sign, and it's a diagonal crease running across the earlobe. It was first formally described in the medical literature in 1973 by an American physician named Sanders T. Frank, who noticed that a surprising number of his patients with coronary artery disease also had this same distinctive fold in their earlobes, and the association has been studied, debated, and restudied in the more than 50 years since. The reason the earlobe matters so much is that it's one of the only places on your body that's essentially just skin, cartilage, and a dense network of tiny blood vessels with almost no fat cushioning it. That makes it a kind of window into the health of your smallest blood vessels elsewhere in the body. If those tiny vessels are stiffening, aging, and losing their elasticity prematurely, the earlobe can fold and crease the same way aging skin wrinkles anywhere else. And the theory is straightforward. If this kind of vascular aging is visibly happening in your earlobe, there's a reasonable chance similar changes are happening deeper inside, in the coronary arteries that feed your heart muscle. That said, Frank's sign is far from a perfect diagnostic tool, and doctors remain genuinely divided on how much weight to give it, because earlobe creases also simply become more common as people age, regardless of heart health. In general, the finding is considered more worth paying attention to when the crease is deep, when it runs all the way across the entire earlobe, and especially when it appears on both ears rather than just one. Even the researchers who study it most seriously tend to describe it less as a diagnosis and more as a conversation starter, a small visual cue that might be worth mentioning to your doctor rather than something to panic over on its own. From the ears, let's move to the eyelids, and a finding that tells a very different and often far more serious story. Look closely at the inner corners of the eyelids, and in some people you'll see flat, slightly raised, yellowish patches sitting just beneath the skin. These are called xanthelasma, and they are, quite literally, clusters of cholesterol. Here's the mechanism. When cholesterol levels in the blood climb too high for too long, that cholesterol doesn't just circulate harmlessly, it begins depositing into soft tissues throughout the body, including the delicate skin around the eyes. Once it settles there, the immune system sends in cleanup crews called macrophages, whose job is to engulf and clear away debris, including cholesterol. But when these macrophages gorge themselves on far more cholesterol than they were built to handle, they swell up and transform into what pathologists call foam cells, so named because under a microscope, they look bubbly and frothy, packed full of fat. Xanthelasma is essentially a visible cluster of these overwhelmed, cholesterol-stuffed macrophages sitting just under your eyelid skin. And the deeper concern is that this same process, cholesterol depositing into tissue and triggering foam cell formation, is exactly what happens inside the walls of your coronary arteries when atherosclerotic plaque begins to form, slowly narrowing the vessels that supply blood to your heart muscle. Consider the case of a 40-year-old woman who came into clinic complaining of chest pain that worsened with exertion. It didn't take long to piece together what was happening, because she had so much xanthelasma clustered around both eyes that it created the visual illusion of her wearing a pair of glasses, a finding doctors sometimes nickname pseudo-spectacles. She also had firm, painless lumps on the backs of her hands and around her Achilles tendons called tuberous xanthomas, another manifestation of the same underlying cholesterol deposition process. The cause turned out to be a genetic condition called familial hypercholesterolemia, an inherited disorder that leads to extremely elevated cholesterol levels from a young age, often long before someone would think to get their cholesterol checked. Because that cholesterol had been silently building up inside her coronary arteries for decades, by the age of 40, she had developed such severe blockages that she needed open heart surgery to restore adequate blood flow to her heart muscle. And here's the detail that surprises most people. Research has repeatedly shown that xanthelasma carries an elevated risk of cardiovascular disease and death, even in people whose blood cholesterol levels test as completely normal at the time it's discovered. That disconnect is part of why doctors take xanthelasma seriously as a signal, regardless of what a single cholesterol panel says, and why finding it is generally treated as a cue to screen more thoroughly for underlying genetic cholesterol disorders and to take a harder look at overall cardiovascular risk. While we're examining the eyes, there's a second cholesterol-related clue worth knowing, and it involves the iris rather than the eyelid. Look for a grayish-white ring or partial arc encircling the colored part of the eye. This is called corneal arcus, or arcus senilis, when it appears in older adults, and it results from the same basic process: tiny lipid deposits accumulating in the outer edge of the cornea. Nearly everyone will eventually develop some degree of this ring simply as a normal part of aging, and by itself, in an older adult, it's not considered particularly alarming. But context changes everything here. If a distinct corneal arcus shows up in someone younger than 45, that's treated as a genuine red flag, one that should prompt a lipid panel and a broader look at cardiovascular risk factors, because premature arcus in a younger person often points toward the same kind of significantly elevated cholesterol that can drive early coronary artery disease. Not every skin and eye finding traces back to cholesterol, though. Some point toward an entirely different and considerably rarer category of heart disease. Around the eyes, some people develop small, waxy, translucent, firm bumps, and these are caused by a group of conditions called amyloidosis. The most common form relevant here is AL amyloidosis, a disease in which the bone marrow begins producing enormous quantities of an abnormal misfolded protein called amyloid. Instead of functioning normally, these misfolded proteins clump together into insoluble deposits that infiltrate organs throughout the body, including, critically, the heart muscle itself. When amyloid deposits accumulate inside the heart, the muscle progressively stiffens and thickens, a condition called restrictive cardiomyopathy, in which the heart loses its ability to relax and fill properly between beats, even though it may still be able to squeeze reasonably well. This distinction matters enormously for treatment, and early diagnosis is genuinely critical because by the time classic symptoms of heart failure develop, like severe fatigue and breathlessness, significant and sometimes irreversible damage may have already occurred. This is exactly why recognizing the visible skin findings of amyloidosis matters so much. Start by checking the skin around the eyes, ears, and neck for those waxy, translucent, firm bumps. Then look at the tongue itself, because amyloid can deposit there too, causing the tongue to gradually enlarge, a finding called macroglossia. One useful clue to look for is scalloping, small indentations along the sides of the tongue that form because as the tongue swells, it presses outward against the teeth. And finally, there's a strikingly dramatic sign worth knowing, so-called raccoon eyes, dark bruising that spreads around both eyes. This happens because amyloid deposits weaken the walls of tiny blood vessels beneath the skin, making them so fragile that something as minor as rubbing your eyes, coughing, or even straining during a bowel movement can rupture them and produce sudden, striking periorbital bruising. Next, let's talk about a skin pattern called livido reticularis, a mottled, net-like, lace-pattern discoloration that spreads across the skin, usually on the legs, and signals something happening with circulation underneath. The reddish-blue, web-like pattern is created by constricted or partially blocked small blood vessels, while the skin in between the mottled pattern maintains a relatively normal color. Importantly, this is not automatically a bad sign. Livedo reticularis is actually quite common and often completely benign, frequently seen in healthy infants and in young women whose blood vessels simply constrict more noticeably in cold temperatures. The key distinguishing features of this harmless version are that it causes no pain and it fades away once the skin is warmed. On the other end of the spectrum, though, livedo reticularis can signal something considerably more serious. It can appear when small fragments of cholesterol plaque break off from the wall of a larger artery and travel downstream until they lodge in the tiny blood vessels of the skin, a phenomenon called cholesterol embolism. It can also appear as a manifestation of serious autoimmune and inflammatory conditions, including lupus and antiphospholipid syndrome, disorders in which the immune system's activity against blood vessels can dramatically raise the risk of blood clots, strokes, and pregnancy complications. As a general rule of thumb, if this mottled pattern appears on your skin and doesn't fade with warming, or if it's accompanied by pain, ulceration, or other symptoms, it's worth a conversation with your doctor rather than dismissing it as simply feeling cold. Now let's move to the fingernails, and one of the most theatrical physical exam findings in all of cardiology. Look closely at the nail bed while resting your hand at heart level, and in some patients, you can actually see the color of the nail bed pulsing, alternately flushing pink and draining pale with every single heartbeat. This is called Quincke's sign, named after the German physician Heinrich Quinck, who first described visible capillary pulsations in the nail beds back in 1868. Here's why it happens. Normally, blood is pumped out of the heart's main chamber and through a one-way valve called the aortic valve, which is supposed to snap shut after each beat to prevent blood from flowing backward. But if that valve becomes damaged and leaky, a condition called aortic regurgitation, a portion of the blood that was just pumped out actually flows backward into the heart between beats. This backward leak creates an unusually large swing between the pressure at the peak of each heartbeat and the pressure in the brief pause afterward. And it's that dramatic pressure swing that produces visible pulsations, not just in the fingernails, but remarkably throughout the body. 19th century physicians documented an entire constellation of these pulsation signs, largely before the invention of the echocardiogram, when a sharp physical exam was often the only diagnostic tool available. There's Corrigan's pulse, described by the Irish physician Dominic John Corrigan in 1832, in which you can actually see the carotid arteries in the neck bounding and collapsing with each heartbeat. There's de Musset's sign, named after the 19th century French poet Alfred de Musset, whose friends reportedly first noticed his head rhythmically nodding forward with each heartbeat as a consequence of his own aortic regurgitation. There's Müller's sign, described by the German physician Friedrich von Müller around 1889, in which the uvula at the back of the throat can be seen pulsating. And there's Landolfi's sign, in which the pupils themselves subtly constrict and dilate in time with the heartbeat. Left untreated, significant aortic regurgitation places an enormous chronic workload on the heart, forcing it to pump extra volume with every beat. And over time, that strain can progressively enlarge and weaken the heart muscle until it spirals into heart failure, which brings us to our next major topic. Heart failure is a state in which the heart muscle becomes damaged, weakened, or stiffened to the point that it can no longer pump blood effectively enough to meet the body's needs. This can develop after the heart muscle itself is directly injured, such as by a heart attack, or it can develop when the heart muscle becomes abnormally stiff and non-compliant, as we already discussed, happens in amyloidosis. One of the most recognizable outward signs of heart failure is a specific type of swelling called pitting edema, most commonly found in the feet, ankles, and lower legs. But it's important not to jump to conclusions here, because pitting edema has plenty of causes that have nothing to do with heart failure. Prolonged standing, certain medications, and even simple gravity by the end of a long day can produce it. There's a simple self-test you can try. Press your fingertip firmly into a bony area of your lower leg, either the shin or the ankle, and hold it there for roughly 5 to 15 seconds. If, after you release, there's a visible indentation left behind in the skin that takes a moment to fill back in, that's pitting edema. So why does this happen specifically in heart failure? When the heart isn't pumping efficiently, blood returning to the heart backs up in the venous system rather than moving through smoothly. Picture a multi-lane highway where a stalled car up ahead causes traffic to back up for miles, and frustrated drivers start exiting onto smaller side streets to escape the congestion. Something analogous happens inside your blood vessels. As pressure builds in the veins, fluid is essentially forced to exit the congested vascular highway and seep out into the surrounding soft tissue, accumulating as edema. Left unaddressed for long enough, severe pitting edema can eventually lead to skin breakdown, ulceration, and infection, though on its own it's rarely immediately life-threatening. Considerably more dangerous is what happens when that same congestion occurs in the lungs instead of the legs, a condition called pulmonary edema, in which fluid backs up into the delicate air sacs of the lungs themselves. This is, in fact, one of the most common reasons patients end up hospitalized with heart failure. And on a chest x-ray, fluid-filled lungs create a characteristic hazy, cloudy appearance that radiologists can identify at a glance. When the lungs fill with fluid like this, the hallmark symptom is orthopnea, a medical term for shortness of breath that specifically worsens when lying flat and improves when sitting upright, because gravity redistributes the fluid differently in each position. It's strikingly common for patients experiencing this to describe, almost sheepishly, that they've started sleeping propped up in a recliner chair for weeks or months without realizing that detail was actually a significant medical clue rather than just a comfort preference. The encouraging news is that once diagnosed, pulmonary edema from heart failure responds remarkably well to treatment. In a hospital setting, under close monitoring, doctors can use diuretic medications to help a patient eliminate 10 to 20 pounds or more of excess retained fluid over the course of just a few days, often producing dramatic improvement in breathing. Heart failure's reach doesn't stop at the lungs and legs either. The elevated venous pressure it causes can back up into other major organs as well, most notably the kidneys and the liver. Many people are genuinely surprised to learn that chronic, poorly controlled heart failure can progressively damage the liver enough to cause cirrhosis, scarring of liver tissue, and in severe, long-standing cases, outright liver failure, a phenomenon sometimes referred to as cardiac cirrhosis or congestive hepatopathy. That connection between the heart and liver produces its own distinct set of visible physical signs, ranging from abdominal swelling caused by fluid accumulation to characteristic changes in the skin and nails, a topic detailed and extensive enough that it deserves its own separate deep dive rather than a brief mention here. Now, for a hands-on test, you can try on yourself right now. Bring the backs of your fingernails together, pressing the nails of corresponding fingers on each hand flush against one another. In a normal, healthy nail bed, this creates a small visible diamond or window of light between the two nails at the point where they meet. But in some people, that little window disappears entirely because the nail and the tip of the finger have become abnormally rounded and bulbous. This finding is called digital clubbing, and it's most classically associated with chronically low blood oxygen levels over an extended period, although researchers have identified several other underlying mechanisms that can stimulate the same kind of abnormal soft tissue growth at the fingertips. The list of possible causes is broad, ranging from chronic lung diseases like COPD or pulmonary fibrosis to certain inflammatory bowel diseases, and, notably for this discussion, several categories of heart disease. In children, digital clubbing most commonly points toward congenital heart defects, structural problems, present from birth that are typically identified and diagnosed relatively early in life. When a physician instead notices new digital clubbing in an adult who was never previously clubbed, it raises a different and more urgent concern: a serious infection of the heart valves called infective endocarditis. These vegetations sit directly on the moving valve leaflets, essentially flailing back and forth in the bloodstream with every single time the valve opens and closes, an image that is exactly as precarious as it sounds, because at any moment, small fragments can break free and travel through the bloodstream until they become lodged in tiny blood vessels somewhere downstream. Where those fragments end up lodging determines which visible sign shows up on the body. If they lodge in the tiny vessels of the fingertips or toes, they can trigger the formation of small, painful, raised reddish bumps called Osler nodes, named after the renowned Canadian physician William Osler, who documented these findings in patients with endocarditis in the 1880s. Alternatively, fragments lodging in the small vessels of the palms or soles can produce flat, painless red or purplish spots known as Janeway lesions, named after the American physician Edward Janeway. And perhaps the single most visually recognizable sign of all shows up on the fingernails themselves: splinter hemorrhages, thin reddish-brown streaks running lengthwise beneath the nail that closely resemble tiny wood splinters lodged under the nail bed. These streaks are actually miniature blood clots trapped within the capillaries of the nail bed. It's important to know, though, that finding a splinter hemorrhage doesn't automatically mean someone has infective endocarditis. A single splinter hemorrhage can just as easily result from ordinary trauma, like accidentally slamming a fingernail in a door, and splinter hemorrhages are also a recognized finding in autoimmune skin conditions like psoriasis. What tends to distinguish infective endocarditis is the pattern. It typically produces splinter hemorrhages across multiple nails simultaneously rather than just one, and it's usually accompanied by other systemic symptoms, including persistent fever, unexplained weight loss, and a general hard-to-pin-down feeling of being unwell that lingers for days or weeks. For the final sign, put down whatever you're doing for just a moment and find your own pulse, either at your wrist or on the side of your neck. Pay close attention to the pattern. Does it feel steady and predictable, evenly spaced beat after beat? Or does it feel chaotic and irregular, speeding up and slowing down with no discernible pattern at all? There's one extremely common cardiac arrhythmia that produces exactly this kind of irregular pulse, and it's considered so clinically important to catch early that many modern smartwatches now include built-in features, specifically designed to alert wearers if it's detected. This arrhythmia is called atrial fibrillation, and it's worth understanding the anatomy behind it. The heart has 4 chambers in total: 2 ventricles, which serve as the heart's main powerful pumping chambers, and 2 atria, which act more like priming chambers, giving blood an extra coordinated squeeze into the ventricles just before each main pump, which makes the entire process more efficient. The atria have comparatively thin, delicate walls compared to the thick, muscular ventricles, and conditions like chronic high blood pressure can gradually stretch and remodel that thin atrial tissue over months and years. That structural remodeling can disrupt the heart's normal electrical conduction system, the network responsible for coordinating each contraction in a precise, organized sequence. Once that coordination breaks down, instead of contracting in an organized, unified beat, the atria begin quivering rapidly and chaotically, essentially twitching aimlessly rather than contracting with purpose. Without a steady, coordinated contraction, blood pooling inside those quivering atria can become relatively stagnant, and stagnant blood has a dangerous tendency to clot. The real crisis moment arrives if one of those clots breaks free from the wall of the atrium, passes through into the ventricle below, and gets forcefully pumped out into general circulation, from where it can travel directly to the brain and cause a stroke. This sequence of events is considerably more common than most people assume, and atrial fibrillation is recognized as one of the leading identifiable causes of stroke worldwide. The reassuring part is that atrial fibrillation is relatively straightforward to diagnose definitively with a heart monitor, once it's suspected, and treatment with blood-thinning medication has been shown to dramatically reduce the risk of a clot-related stroke in people living with this condition. So, if you or someone close to you has ever noticed an irregular heartbeat, even one that seems to come and go rather than being constant, that's not something to brush aside or wait out. It's worth getting evaluated. None of these signs are a diagnosis on their own, and plenty of them have entirely harmless explanations depending on context. But taken together and taken seriously, they represent more than 150 years of accumulated medical observation, distilled down into something anyone can check on themselves in a matter of minutes, using nothing more than a mirror, a fingertip, and a moment of genuine attention to a body that's often trying to tell you something well before it starts shouting.